Hello and good evening, everyone. Welcome back to my IVF Fences and the European Fertility Society. We are back with Dr. Harry Karpouzis. You can see him right here. Hello, good to have you back. It's been not so long ago that we had a chance to discuss PRP, I believe. And now we will focus on unexplained infertility. So Dr. Harry Karpouzis, Scientific Director of Pelargos, which is located in Athens, is back with us. Good to have you. How are you?
I'm fine, Caroline. Nice to see you again, and nice to meet everybody and discuss about one more very interesting subject. Yeah.
Definitely. And if you've had a chance to be here before, you know that Dr. Harry will be happy to answer any of your questions. But first, we will start with presentation on this particular topic. Is unexplained infertility always what it seems? And then we will take care of the questions. So remember, just put those in the chat during the presentation afterwards, and it's all anonymous. So I can only encourage you to take your time and simply put the questions so that Dr. Harry can help you out with them. Remember to provide some details. Obviously, I will be monitoring the chat, so just be patient with us as well. We will try to answer as many questions as possible. We have about 1 hour for the presentation and the Q&A sessions. I believe it will be enough time, but of course, remember, it's all being recorded as well. So you will have a chance to watch it if needed, of course. And now I think that we can go ahead with our presentation. And yeah, ready to start, Dr. Harry?
Sure.
Brilliant. Thank you so much. Let's go for it.
Okay. We will talk today about unexplained infertility, and if it is what it seems like, if it is really unexplained. Let's start from the definition. So, what is unexplained infertility? According to the most recent definition, it is when we have standard fertility testing that has failed to identify an obvious reason of infertility. So, to be completely honest, unexplained infertility is a known diagnosis. But the next question is, what is standard testing? Again, there are conflicting opinions on that. According to the American Association, the standard testing includes ovulation assessment, a sperm test, HSG, which is the test to check about the tubes, ovarian reserve evaluation, and laparoscopy. There is no general consensus on what is supposed to be the standard testing. And that's why the rate of unexplained subfertility can vary between 15 to 30%, which is a very common type of infertility. According to the ESRE guidelines, again, the assessment of ovulation and luteal phase, HSG or laparoscopy, semen analysis are the baseline tests, the basic tests. But there are also controversial opinions if we should include in the baseline testing prolactin, ovarian reserve, which is the AMH that we all know, and the antral follicular count, and biopsy, etc. So let's go through some statistics. 1 in 6 people worldwide are affected by infertility. 15 to 30% are supposed to be unexplained infertility, depending on the definition of unexplained infertility that we give. When a couple is trying spontaneously to get pregnant, 13% of them, if we take the whole group of ages, gets pregnant in the first year, 35% on the second year. When we talk about young women, 80% of the women, if they keep trying for 3 years to get pregnant, they will get pregnant in these 3 years. Keep in mind that the rate drastically reduces if the duration of subfertility is more than 3 years, and if we talk about women that are more than 30 years old. What are the causes of unexplained infertility? I mean, the question is a bit weird because by definition there are no causes. But what if further investigations are performed? And what are the investigations that we can perform and they are not included in the standard testing? It's immunological reasons, it's hidden sperm factors like DNA fragmentation, for example. It's the quality of the egg, it's the implantation window, it's chronic infections, it's the pH of the endometrium, endometriosis, luteal phase deficiency, hormonal imbalances. When the tubes are not healthy, because
Dr.
we
Harry,
might have patent tubes, but it doesn't mean that
excuse
they will
me,
be
can you
healthy as
hear
well.
me okay? Dr. Harry, I'm sorry to interrupt, but I wanted to stop because I believe we have some problems with the sound actually. So are you able to double check if you don't have another window opened with the same link?
Yes,
Just in
give me
case.
1 minute.
Sure, thank you. Because there is some kind of echo, and I think that might be the reason. As I see two, it looks like you are logged twice. That's why. Let's see if we can check it. Bear with us, everyone. We are trying our best to simply make sure that the sound is okay.
Is it better now?
I can hear you better. Let us know if this is okay, but I think it's better. Thank you,
I
Fiona,
think
for
it's better
confirming.
for me as well because I don't
Perfect.
listen to my voice
Yeah,
twice. Is it
now
for
it's
everybody?
definitely. We
Yeah?
can hear you properly now. Much
Okay.
better. Everyone is agreeing with me here,
All
so we
right,
can
good.
continue. Thank you so much.
So I was saying the last slide, which is what are the causes of unexplained infertility? And I was saying that by definition there are no causes, but what if we further investigate? And what are these further investigations that we can do? If we look deeply inside the unexplained infertility, there might be immunological reasons, hidden sperm factors like the DNA fragmentation, quality of egg, the implantation window, chronic infections, the pH of the vagina and the endometrium, endometriosis, luteal phase deficiency, hormonal imbalances. When the tubes are not healthy, and you might have patent tubes, but it doesn't mean that they will be properly working as well. Blood clotting disorders, all these are factors that are not investigated many times in the baseline tests. And of course, we have environmental factors that can cause subfertility, like stress, like smoking, like drinking, like vitamin deficiencies. Let's start analyzing some of these reasons, okay? And start from the environmental reason. Smoking. We know that the chances are twice as low per month to get spontaneously pregnant if you smoke. We know for sure that it affects the DNA oxidation, fragmentation, and the oxidation. We know that it is associated with reducing the chances of success of an IVF. We know that it affects hormones. It can reduce the FSH and the estradiol levels. We also know that the effect of smoking is transient rather than permanent, which means that if someone quits or smokes, it can help, and someone can help him and herself to get pregnant. So smoking is something that can affect and can cause subfertility that we don't know why it is caused from, and it might be because of smoking. Drinking. We know that the quantity of drinking, and especially binge drinking, can be detrimental both to the egg and the sperm. It affects again the sperm, the oxidation, the DNA fragmentation. It causes 50% less chances to conceive in a month. It gives you less chances in IVF when a woman consumes more than 4 units of alcohol per week. So the quantity that someone consumes plays a role as well. And we know that what is the way of doing it? It can increase LH, it can increase estradiol, it can cause hormonal imbalances, it can cause abnormal creation of the follicles, recruitment of the follicles, and endometrial receptivity. Stress. Everybody has got stress, and sometimes we don't find any reason. And stress can be a contributing factor either together with other factors or sometimes even by itself. We know that women with depression have half chances of getting pregnant spontaneously. We know that someone that is a very stressed person, and this is something that you can find with relevant tests that in the saliva secrete specific substances, it takes 29% longer to get pregnant. Anxiety reduces chances. There is data for that. And also keep in mind that there is a circle, especially with unexplained subfertility. Unexplained subfertility is the type of subfertility that causes the most stress. It is proved because it is very difficult to know that you don't find any reason. And this is causing a lot of anxiety, a lot of stress, and the stress is causing infertility as well. And we know that there is an explanation on that. We know that cortisol reduces the estradiol production and can possibly affect the egg. Vitamins, vitamin D, we know that it is a very important vitamin that can help with the sperm count. It can higher the miscarriage rates. Vitamin B12 in women that are vegetarian, for example, the deficiency of that can affect iron, folic acid, omega-3 fatty acids that increase the blood flow to the uterus. And when someone is not taking enough of them, can have problems. Coenzyme Q10, and of course the BMI, if someone is obese or, I mean, the BMI is very reduced, all these factors can also contribute either by themselves or together with other reasons or leading to other more important reasons. And there are factors that can cause infertility. And many times they are factors that we see that people with unexplained subfertility have. Let's go to thrombophilias. Thrombophilias is mainly a reason of recurrent miscarriages or maybe recurrent implantation failures in IVF. And not all the thrombophilias, because there are many different thrombophilias, but there are some specific ones like the factor V Leiden, like the prothrombin mutation, like the protein CNS deficiency, like the MTHFR, and not when someone is heterozygous or when someone is homozygous of these. All these factors can cause recurrent miscarriages. We know about that. When someone is miscarrying all the time, in the end, it's infertility, and in the end can be unexplained as well. But specifically about the MTHFR or homozygous patients, we know that it is related to infertility itself as well, not only to miscarriages, but infertility itself. And how does it work? Usually, most of the theories behind it is that it causes thrombosis in vessels, and this affects the blood flow to the endometrium. Let's go to sperm. Okay, sperm analysis, everybody does it. But what about DNA fragmentation? What about oxidation? 20 to 30% of the men that have normal sperm analysis, if you do DNA fragmentation, if you do oxidation, you will find out that it is increased. And these are tests that are not in the baseline tests. And everybody with unexplained infertility should be testing as well before deciding what's the next route of treatment. We know that we have specific tests for that, which is the DNA fragmentation, and it is the Myoxis test. In our unit, we always do both of these tests, Myoxis and DNA fragmentation together. And we know sometimes that in men, for example, that take antidepressants, we have the opposite problem. It's not oxidation, it is a reduction of the sperm. And when someone is taking antioxidants without really knowing that the problem is not oxidation, but it is a reduction, it can make things even worse. So these tests are important even for IVF to know what exactly you are doing. And of course, there are more rare tests as well on the sperm that if you decide to analyze about everything, you can analyze about everything. And we will go there if it is needed or not, but we will talk about that later. Endometriosis, one of the most important factors of unexplained infertility. And what is the diagnosis of how do we diagnose endometriosis? The golden standard is laparoscopy. Okay, 20% to 30% of the women, even if they are not symptomatic, if you put a camera and you put them inside their tummy, you will find out that they have endometriosis. 30 to 50% of the women with infertility have endometriosis. Very often it's combined with adenomyosis as well. We have laparoscopy, we have some genetic new tests as well that you can find out about endometriosis, like Receptiva. And how does it cause infertility? Many different factors, many theories. It causes inflammation cascade. It can affect the tubal motility. It can affect the quality and number of eggs. It can affect the endometrial implantation. It can cause gene alteration in the endometrium. It can increase specific enzymes in the endometrium like aromatase, and affect the hormonal balance, which is very important for the implantation window. And it can cause progesterone resistance as well. And also, very often, it is associated with immunological problems in the endometrium. So, endometriosis is crazy, it can do everything. Now, immunology. Many times it's an immunological issue. There are conditions like APS, like SLE. There are local factors in the implantation window that play a role in implanting an embryo. But many times when this balance is affected over there, it can cause either miscarriages, repeated miscarriages, or recurrent implantation failures, or, infertility. And in women that have the history, we prefer to do a test which is called IMAP. It's based in reports from a very famous French immunologist who is called Ledet, that actually assesses the natural killer cells, the Th1 ratio towards the Th2, the regulatory T cells, inflammation, hormonals inside the endometrium, and then we get a protocol about what exactly we need to do. Because, I have noticed that in many clinics, many people are giving steroids, but, sometimes the problem might not be the steroids, might be the opposite. So if you give steroids, you might make things worse. Genetic reasons, many genes are associated with subfertility, cystic fibrosis, Tay-Sachs disease, spinal muscular atrophy. There are genetic tests for that. And there are now sequences and panels of tests, both for the man and the woman, that can show a genetic problem, a gene that is causing infertility. And also chromosomes. Very often we have men and women that have translocations in the chromosomes, balanced or imbalanced. They are normal people. They don't know that they have any other issue. And the only issue is subfertility. So then you do a karyotype on them and you find out that they have translocations and things are difficult. Endometrium. Many times we have a chronic infection, which is called endometritis. Many times in a normal ultrasound, we will not be able to see a small degree of adhesions, and we need a hysteroscopy for that. Many times it's a matter of the flora inside the endometrium. There are specific tests for all these things that we can do to investigate about in women, of course, that have a history that requires to test about all these things. Adenomyosis sometimes can go inside the endometrium as well. Herpes infection can affect in many different ways. Tubes, as I said before, where the tubes you do a test and you say that the tubes are patent. Okay, that's good, but do they properly work? And we don't have any way of finding out if in a cell level inside the motility of the fibria, etc., of the tube are properly working. So you might have a patent tube, and finally, it's not properly working to help with the fertilization. And this can be caused from past infections like chlamydia, mycoplasma, uroplasma, all these infections. Hydrosalpinx. Many times it's obvious in a scan and it needs removal before IVF because it's a tube that is not working and it reduces the chances. Fibroids are obvious, but sometimes when you have an intramural fibroid that is not completely inside the lining of the womb, but it is close to the lining of the womb, it can affect the blood flow to the endometrium. And then you find yourself in a very difficult question. Is it affecting my fertility or not? Does it need removal or not? Well, the answer is that every case is different. Hormonal imbalances. Luteal phase defect. Many women might have this issue or might have heard of this issue. We are talking about women that have a shorter cycle, have a shorter luteal phase that lasts less than 10 days. And how do we identify a woman? First of all, shorter cycle. Second, progesterone insufficiency. Third, they might have premenstrual spotting before the menstruation, or they may have a history of early miscarriages, biochemical pregnancies, etc. And what we are doing in this case is, it's a matter of progesterone support, and it is one of the reasons of the causes of unexplained subfertility, that if someone identifies it and is in a good age without any other problems, can sort it out without really the need of an IVF. Because, most of the reasons of subfertility are treated, unexplained infertility, are treated with IVF. So what tests do we use? What are our weapons to investigate more thoroughly, more deeply? It's laparoscopy, it's tubal tests, it's hysteroscopy, it's ERMAP, ERA, ALICE, EMMA tests, check about celiac disease, about herpes, about AMH and antral follicular count, because many times we say unexplained subfertility, and if we don't go through the right definition of unexplained infertility, I mean, the answer is very obvious. It's poor ovarian reserve, actually. TSH, prolactin, progesterone in the luteal phase, thrombophilia testing that we talked about before, tubal tests like HSG, HICOSI, ultrasounds and 3D ultrasounds to help about, by cornea to uterus, etc., that it's difficult sometimes to find out. Vitamin D tests, folic acid, iron, DHEA, karyotyping, genetic testing that we told before, DNA fragmentation, meiosis. All these tests are tests that can help identify unexplained subfertility and if it is really unexplained or not. Let's go to this slide. The more someone investigates, the less the rate of unexplained infertility will be. More tests, more reasons are found. But what about cost? Do we put every woman into doing all these tests so that she can find the reason? Because for most of the reasons, even if she finds the reason, the solution would be IVF. And IVF is a costly treatment. And the tests, some of them, like natural killer cells and other tests, are very costly as well. So the answer to all that is that, to the question, does it worth spending money in expensive tests, even if we do identify a reason, the only solution would be the IVF or ICSI? And the answer is discuss it with the couples, okay? The couple needs to know what would be done. If she finds out, for example, that she has poor ovarian reserve, what she will do if she finds out that it is DNA fragmentation? Okay, you know that sometimes the answer is IVF, okay? What is the treatment of unexplained infertility? First of all, is it really unexplained? To what extent have we investigated? Do some lifestyle changes. If you are young, if you are fit, if you are healthy, if you don't have any other issues, you might choose to have a bit of expectant management. Acupuncture, it will help you with the stress. It will improve the implantation rates. It can help with the number of the eggs, hormonal balance. We have in our unit body-mind stress relief techniques, okay, that help a lot with yoga or other things. Vitamins replacement. Okay, all these things might help, and you finally, if you don't have any other issues, get pregnant by yourself. What about expectant management? How long can we try? Expectant management up to 2 years if a woman is less than 35 years old. What about IUI? IUI is a difficult answer. IUI in women with normal cycle and normal sperm is not recommended usually for unexplained infertility. This is the nice recommendations. If someone insists on having an IUI because doesn't want to jump straight to IVF, DNA fragmentation should be checked before, because otherwise if you do IUI and you have DNA fragmentation, it will not work. AMH should be checked, because if the AMH is very, very low, it will never work. The chances will be exceptionally low. If someone is more than 35 years old, no expectant management more than 1 year, because time plays a role. IUI can be an option only in a very specific category of unexplained infertility patients. Women with mild variations of ovulation that will be helped as well from clomiphene or letrozole medication, slightly reduced sperma, no DNA fragmentation, open tubes, and good AMH that do not want to jump straight to IVF. Treatment. Either before IVF or for spontaneous conception, check thyroid, check prolactin. When someone has luteal phase defect, it's one of the very few reasons that can be corrected with progesterone or beta-HCG or Ovitrel after the ovulation, and someone can get pregnant possibly by herself if she doesn't have, of course, other reasons. So it is one of the things that it's nice to identify so that you can avoid IVF. If you have a hydrosalpinx and it is found, remove it, okay? If you have endometriosis, it's a difficult question of what you are doing. If you decide to do laparoscopy and treat endometriosis and the tubes are open and patent and no other problems and you find endometriosis, you can try for conception in the next 6 months so that you don't go straight for IVF. But of course, you need to take into consideration other factors as well, okay? We are talking now about unexplained infertility. So obviously, we are not talking about problems in the sperm, but what about low ovarian reserve? In cases of low ovarian reserve, it's better to jump straight to IVF. If someone has endometriomas, which are cysts from the endometriosis, remove them or not. It's a very critical decision. We have discussed many times about that. It depends again. If we have previous surgery, it's better not to play around again with them. If we have low AMH, it's better to avoid and stimulate straight away with IVF. If we have adhesions and we identify adhesions in the hysteroscopy, for example, remove it. It's the same with polyps. If we find immunological issues by one of the tests that we have done, there are many weapons that we have: steroids, progesterone, placanil, intralipids, aspirin and Clexan for thrombophilias, probiotics if the flora is not okay. Sometimes the endometrium is not getting thick without really finding any reason for that. PRP, GCSF that we talked in other presentations might be a way of going around. Anti-herpes medication if we have herpes history. And what about the sperm? Many techniques, sperm selection techniques, Zymot, MAX, antioxidants, okay? If we really have oxidation, there are some new reports that say that even if the oxidation is okay, but it is between 0.5 and 1, it is better to do Zymot if you use ICSI. So if you use ICSI and you don't do Zymot, you don't select, and you have oxidation between 0.5 and 1, which is considered to be normal, again, might have issues. And what about chromosomes? PGTA for chromosome checking of the embryo, PGTSR for translocations, PGTM for genetic reasons. Let's go to the final slide. It's one of the most difficult types of subfertility. The definition is very important. It's always better when you know what you treat. So the label unexplained subfertility depends on how thoroughly you want to investigate. Usually the best solution is IVF. Many times, though, spontaneous pregnancy is achieved with expectant management. Diagnosis is very important, but it's not a panacea. It's not something that we need to have, because you might spend lots of money in finding a diagnosis, and then the result and the solution for that would be IVF. Extent of testing needs to be discussed with the couple, and specific tests are for specific medical histories. And in many cases, unexplained subfertility is very simple. It's just low ovarian reserve. The solution in most of the cases is IVF, and people with unexplained subfertility need to be managed holistically, because unexplained subfertility can cause lots of stress and lots of problems.
Thank you so much indeed, Dr. Harry. I'm glad that we were able to fix the issue with the sound. I believe it was okay. So thanks a lot for letting us know about this as well. And of course, thank you for the introduction to our topic, of course, and walking us through all aspects. As you mentioned, there can be a number of reasons which we need to look out for. So now, of course, there will be time for your questions. So if you have something that's on your mind, you know what to do. Dr. Harry is right here for you to simply answer them. So let's have a look. Elena has the first question. So let me just show it to you. I'm not familiar for sure with this test, so I prefer to just simply show it to you. Just give me a second. Here it is. So hello, do you test cat sperm mutation as well? How much is this test, if so?
Okay, listen, this is a mutation that has been associated with male infertility. It can affect the motility of the sperm when someone has this mutation. In one of the tests that we do, that it's the male panel, okay, of FertiScan, it's included this mutation as well. The question is, okay, you do the test and you find out that you have this mutation, what you are doing after that? So, I mean, the management has to do not with identification of the specific thing, but the management has to do with what we are doing. Because if we are talking about azoospermia, for example, then we will need to decide if there is any possibility of finding sperm with TISE or any possibility of finding sperm generally. So yes, it's one of the mutations that we can find out if someone has the genetic problem, but what after that?
Okay. I hope that helped you. If there are any follow-ups, you know what to do. Just type those in the chat. More questions are coming in, so keep them coming for sure. And let's have a look at the next question. Can I ask if NMN is good for improving egg quality?
I mean, I'm not
Are you
familiar with
familiar?
the NMN. Most probably we mean something else. I don't know.
Sure, if you can just type what exactly it is, we
Yeah.
are. Nico, okay, I will show it to you. That will be much better indeed. So just give me a second. And here it is. So it's here. Nicotinamide monochloride, sorry.
I see. I didn't get there. Yes. Okay. It
Thank
has
you.
some good data behind it, and it's in one of the multivitamins that we usually propose to people for improvement of the quality of the egg. But you need to know that there is no magic way of improving the quality. There are some antioxidants actually that can help with the quality according to some data. It has some data behind it. To be completely honest with you, I'm not familiar with the newest reports to evaluate them and see if it is really that important or not. But yes, I understand now. Yeah.
Okay, thank you for the clarification. Remember, it's always better to to simply add all the information that way. It's just much easier for sure. All right, more questions are coming in, and we will now look at the question from Emily here. All right, so is it possible that even without treatment, couples can eventually conceive on their own? How often does this happen? I am 34. We're just starting testing AMH and sperm is okay.
Yes, of course. So there is a possibility of people getting pregnant by themselves. That's the point of unexplained subfertility, that we don't find the reason. So, I mean, as I said in the presentation, I mean, if you are less than 30 years old, okay, about 80% of the women in 3 years of trying get pregnant. So if someone has not got pregnant in the first or the second year, in the third year might get pregnant. In 34, it's not 80%, it's a bit smaller the percentage, but still, expectant management can get you pregnant in unexplained infertility. But a couple is considered to be subfertile when the woman is less than 35 years old, when the couple is trying for 1 year without a result. So if we reach that stage, then we needed to start investigating about the basic things. And if the basic things come back as everything okay, then this, according to the main definition, is unexplained infertility. And then you have two options. The second option is to try for 1 more year because it might happen, okay? And that's the first option. And the second option is to say, okay, listen, I want to expedite that. I don't want to wait more. And let's go to the next step. The next step is usually IVF, unless in a very specific category of women that I explained in the presentation that might try IUI as well.
Okay. Again, thank you so much. I think that that should answer your question, what to do next. So thank you again for that. And let's have a look. Okay, we have another question here. So what are the benefits of myo-inositol? Can you take it whilst undergoing IVF?
Yes, it's good. It has some data that it helps mainly in women with polycystic ovaries. Okay, we have some multivitamins that we included in, especially in women that have irregular cycle and polycystic ovaries, and it has good data behind it. Yes, you can keep taking it during IVF, and also you can keep taking it during pregnancy as well.
Okay, thank you. Quite clear. It's okay to go ahead with it. And I missed one question, but I have it right here. I had ectopic pregnancy. One tube was removed, other blocked. I have PCOS, insulin resistance, NK cells 1%, MTHFR heterozygote. As you can see, the details here: antiphospholipid syndrome, okay; lupus, PRL, and thyroid hormones are okay; hysteroscopy also okay. I am 38, had 3 miscarriages in the last 2 years with 7 blastocysts, frozen when I was 37, 36. What else to test? I have 2 more blastocysts left. Anything you can advise here?
Okay, listen. I mean, the answer to the question is that you have one tube blocked, 38 years old. The solution is usually IVF. You have checked about many things, I can say. One question about the natural killer cells is if you have done a blood test or a biopsy inside the endometrium, which is, according to us, sometimes more accurate because it is done after specific endometrial preparation. I mean, thrombophilias and things like that, I think that you have said that you have checked them. I cannot see now the question, but I mean, with 3 miscarriages, it is something that you need to check about thrombophilias and blood clotting. But the question and the big thing is, I mean, polycystic ovaries themselves can cause miscarriages. So one of the things that you can try as well is about glucophage, which, according to some studies, can help in miscarriages. And the most important thing is the blastocysts that you have transferred are PGT8 blastocysts. Have they been checked about the chromosomes or not? Because you are 38, okay, I don't know how the sperm is, etc., as well, and if it has been investigated very thoroughly about DNA fragmentation and things like that, because with history of recurrent miscarriages, always we need to check thoroughly the sperm as well. And I would suggest, with all that, the next time to know if the embryo that you will put back will be chromosomically normal or not. Because if you put another embryo that you haven't checked, it might miscarry again. And then again, you will not know if the problem is the embryo or if the problem is the endometrium or something else. So the first thing is to create a chromosomically normal embryo. And then there might be some other tests that you haven't done. I mean, about the MTHFR heterozygote, I wouldn't worry a lot. The factor V Leiden is normal, antiphospholipid is normal, hysteroscopy is okay. You have done plenty of things there. But about the history of miscarriage, might have some other tests like chronic endometritis as well to check about. A biopsy about chronic infections, and the most important thing, to create some normal embryos before you put them back, because otherwise you will not know what happened.
Okay. Thank you again for a thorough answer, Dana. If there's anything else you would like to add, go ahead, type this in. Of course, I believe it was already quite helpful for you. More questions are coming in, and let me just show you the next one. Again, a bit of a longer story here. I'm 44 with a 2-year-old, 1 chemical pregnancy in October 2022, 1 miscarriage at 9 weeks, April 2023, 1 missed miscarriage at 4 weeks, happening right now. I've had lots of tests. Some endometriosis removed was last year. Some issues with husband DNA, have been working on diet and with supplements for 2 years. What do you think my next step should be? An independent fertility specialist recommended IVF with own eggs because my figures are good. But at my age, is that realistic?
Chances are very low in your age, okay? Even if you have a good AMH and a good antral follicular count, of course, this is important, but unfortunately, most of the times the problem is chromosomes in the embryo, and this depends on the quality of the egg, which in this age group is usually quite reduced. I mean, I don't know the full history. I don't know exactly, previous protocols and things like that. You need to answer yourself to the question: am I ready to jump to the stage of egg donation or not? If you are ready to jump psychologically to the stage, go there, because most probably you will get pregnant. If you want to try it again, we need to go thoroughly through everything, discuss everything. And one of the things in this age group that I would advise, again, is the same like the previous lady. Do a PGTA test, because this way you will find out what is the issue. If you manage to achieve through all that a chromosomically normal embryo, then obviously this is a very precious embryo. And then we go step by step in checking everything else before we put it back. And if you manage to create a chromosomically normal embryo, then most probably you have good chances. But the problem is to reach this stage, okay? And there is no miraculous way of improving the quality or anything like that. In your age group, you need to get as many eggs as possible. The number of eggs that you get depends on the number of follicles that you have, though. And then getting a chromosomically normal embryo and then investigating everything else.
All right. Thank you once again. Straightforward answer. You should know what to do next, of course. And let's have a look. The question is, so which vitamins do you suggest for better egg quality? Anything you can still advise here?
Listen, I will not say the brands, of course, of the vitamins that we work with, but as a general rule, the studies that the vitamins that have most studies behind them is coenzyme Q10, is vitamin D, is folic acid, is iron, of course. It's B vitamins like B12, B1, B6, and we have some good studies behind melatonin as well. Okay, for the egg quality, talking now.
Okay, thank you for that. It's a question that is asked quite often, so thank you so much for repeating this as well. Let's have a look. Do you recommend patients working with a fertility health coach to help with stress and lifestyle modifications to help with preconception? Anything you can advise on here?
Sorry, I missed the question. Can you repeat,
Sorry.
Caroline?
Yes, of course. Do you recommend patients working with a fertility health coach to help with stress and lifestyle modification to help with preconception? Do you
Yes,
work with any?
we do. I've said in the presentation as well that, listen, first of all, the expectant management and trying to get pregnant by yourself can happen in unexplained infertility. And there are many things that help, but of course, you need to take the whole picture as well. So if someone is 42, it's better not to do expectant management. If someone is 33 without any problems, can choose to try up to 2 years. Stress and other things, of course, can affect, and that's why we do have some body-mind techniques, yoga techniques, acupuncture as well. All these things can help with the hormonal balance, with the regulation as a stress relief, reducing the cortisol levels, and helping generally with spontaneous conception if you want to try them, of course. Okay, they have some data behind it, and they can work with different mechanisms. So you don't lose anything if you want to try all these things. And of course, a healthy lifestyle and diet and specific diet for fertility as well. So all these things might help if someone wants to keep trying. Okay.
Okay, crystal clear again. Thank you so much indeed for that. All right, there are a few questions, so more, but of course, if you have anything else to add, you know what to do. All right, so amongst all the problems that you highlighted in your experience, what are the most common related to repeated implantation failure? We've already transferred 10 blastocysts, 4 of which were PGTA tested.
Okay, that's a difficult case, obviously. Okay, when first of all, it's not by definition unexplained infertility; it's recurrent implantation failures, which is a different topic. But by any means, 10 blastocysts. We don't know what were the chromosomes of 6 of them, but 4 of them were normal, I suppose, and they were transferred and it didn't work. I mean, all the tests that I mentioned before, can cause sometimes implantation failures as well. I mean, I would check about the implantation window, even though the latest reviews do not give it a lot of evidence, but we have very good experience about the implantation window, okay? Because if someone is transferring normal chromosome blastocysts and they are not working, maybe someone needs an embryo transfer like one day or later, one day, earlier. I mean, specific testing that has to do with the local factors inside the endometrium, like the one that we are doing in the clinic, it's also important because it might come back with a protocol that you haven't used, like Placanil, for example, which is a medication which is very important, has helped many people many times. And also, it's what I've said in the presentation that many times we keep giving steroids and things without really knowing what is the reason. And if someone does not have an overactivity of the immune system, it has an underactivity, and we keep giving steroids, we might be doing things worse. and transferring healthy, viable embryos and actually creating the problem. So I would check everything that we can check because there are things that we cannot check and we don't know why. And if it fails again with a normal chromosomically embryo, and we say that we have done everything, then of course sometimes the next solution would be surrogacy. Yeah.
Okay. Thank you once again for that. Let's have a look. Next patient would like to ask you this. I am 40. I have very low AMH at 0.53 nanograms. Hormone test otherwise okay. Regular cycles. HHG showed no tubal issues. Sperm tests okay. Been trying just over a year. Would you recommend going straight to IVF with own eggs or donor eggs?
Well, I would try an IVF with your own eggs. Okay, it's low, but we have achieved pregnancies with even lower than that. I mean, if you compare chances, definitely in your age group, the chances with donor eggs will be better. But if you want to try it with your own eggs, you do have some chances. You are 40, you're not 44, and you can give it a try before jumping to egg donation.
Brilliant. Thank you here for the reassurance as well. All right. This is a follow-up from Dana from previous patients. So would you recommend uterus PRP? So for my case, for recurrent pregnancy loss.
PRP for what? Is there a problem for with endometrium? I mean, if it is thin endometrium, then yes, I mean PRP together with GCSF or anything like that can be an option. But if the thickness of the endometrium is okay, PRP it's not one of the treatments that we usually do in recurrent implantation failures. I mean, we do specific testing, and if the specific testing shows that we need to use something for the endometrium, it might be another medication, which is GCSF, Neupogen, yeah, that might be helping in unexplained reasons of non-thickening endometrium or unexplained reasons of implantation failures. So PRP, we only use it when we do have problems with the thickness of the endometrium.
All right. Hope that helps again. Thank you so much. 2 questions left. So if you have any more, this will be the final call for those questions. And let's have a look. Okay. Next patient would like to know, I'm 41 and have a 3-year-old that I conceived in the first month. We are trying for the second, got pregnant straight away, but miscarried, trying for almost 2 years with 5 fake transfers. What tests are vital for secondary infertility?
I mean, you have done already 5 transfers, yes. So I suppose that the baseline tests and everything you have done them.
Looks like it,
I
yes.
mean, secondary infertility. In your case, it's the first child was when you are 38. Between 38 and 41, it's a big difference. Believe it or not, after 40, we have a very significant reduce of quality and number of the eggs. So, I mean, the situation in comparison to what you had when you got pregnant in 38 might be completely different now. I don't know if the embryos that you have transferred were PGT8 embryos or not. If you want to keep trying, I think the most quick and better successful way of trying in your age is IVF. I would check to see if I can create some chromosomically normal embryos first, because it's a way of seeing as well what is the problem. So if you do another IVF, I would check the chromosomes of the embryos and find out if this embryo is normal or not. If it is not normal, you have an answer. It's a matter of chromosomes. So it's a matter of age related. So then you need to decide if you want to keep trying, what we can do different, what we can change, how many eggs we need to get to give you some better chances. And it is always a matter of luck as well, of finding the one embryo that will get you pregnant. Now, about all other tests, there are many tests. I've mentioned them in my presentation. We can investigate about many different things about why an embryo is failing. But when someone is 41, the most common reason of failing is chromosomes.
Okay, thank you once again for this. All right, we talked about equality and supplements. How about supplements to improve sperm quality? And how long does it take until it shows positive effects?
Yes, as I said before, I have a small issue with all these antioxidants regarding sperma because, in our patients, I usually prefer to see a sperm analysis. Okay, I go through the history. If someone is having unexplained infertility, is having recurrent miscarriages, recurrent implantation failures, I prefer to evaluate the sperm. So I prefer to check the sperm, not on vitamins, but just without vitamins, to see if it is a matter of DNA fragmentation and oxidation or not. Because all these vitamins that help with the sperm, most of the times are antioxidants like carnitine, glutathione, NMS, and NMN that someone was mentioning before.
Mm-hmm.
All these things work more or less in a specific way of reducing the oxidation. But many times, we check the sperm and it's not a matter of oxidation, it's the opposite one, it's a reduction. And then you give all these antioxidants and you make things worse rather than better. So first you check and you see what is the issue. Then other medication about sperm, it depends. If it is a matter of very reduced sperm, we give treatments that have to do with beta HCG, with clomiphene, for example. All this medication can help improving a bit the sperm, but when we have really bad quality of sperm. So we investigate first, we see what is the issue, what exactly is the problem, and then we give vitamins. Regarding the vitamins that it's the question about, antioxidants, carnitine, glutathione, or selenium, are many vitamins in the market that have all these things and can help with oxidation. Some of them are better, some of them are worse. We work with specific ones. Every doctor gives a different one.
Sure, of course. Thank you so much indeed. And now we will probably go for our final question for today. So let's have a look, okay? So I am 40, I have 6-year-old conceived naturally. I have low AMH, I have had 4 failed IVF from embryos which have been genetically tested. I have had 4 miscarriages which was conceived naturally. I was recently diagnosed with blood clots. What are my chances and further steps?
With blood clots, you mean you had a blood clot or a DVT or blood clotting problems?
Let us know if you can proceed. Yeah.
Okay, it's difficult, and it's a nice case here because we have someone that had a child who is 6 years old that was conceived naturally, and then
Blood
we had
clotting
miscarriages. Sorry.
problem. It's just
Blood
Elena
clotting
wrote.
problem.
Yeah.
Okay, blood clotting problem. And then we have miscarriages with chromosomically normal embryos in a woman that has given birth before naturally. And, so it's weird. About the blood clotting issues, it depends on what blood clotting issues. And of course, Clexane, anti-clotting injections, aspirin will help with that. So if it is a matter of thrombophilia, indeed, there is inherited thrombophilia and there is acquired thrombophilia. So you might have acquired thrombophilia, in which case anti-clotting injections and aspirin will help a lot if you have investigated all the other issues. I would investigate a bit more about immunology as well, because you might have immunological issue that has come up after the pregnancy. It's quite common. So further investigations to test about why you are miscarrying with chromosomically normal embryos might be needed. Yeah.
Okay. Again, thank you so much. In the meantime, we did receive one more question. I think we can still answer that. Let's have a look. What are your suggestions for treating KIR HLIC mismatch with medium risk? GC SF uterine wash could be a good solution. Can it explain recurrent implantation failure? Backgrounds: 6 frozen embryo transfers, 8 untested embryos from age 34, 35, but also euploid embryo produced at 37. Almost all listed tests are done and negative except laparoscopy. Ultrasound shows small possible endometriosis only on DIE, but healthy ovaries, uterus, shall it be still removed? And additionally, EBV, detected in uterine microbiome.
Yes, in situations like that, GCSF is a medication that we use and it might help. We don't do any other treatments in Greece when we have a problem like that with the HLA-C mismatch. So GCSF is one of the treatments that we use. Now about the endometriosis, I mean, I
I will
wouldn't,
show it to you just
if
a
there are
second.
no symptoms of endometriosis and there is no reason of doing endometriosis for pain or anything like that, to be honest with you, if we have a diagnosis of endometriosis indeed, or if we suspect that we have endometriosis, I would just downregulate the ovaries with GnRH agonist injections before the frozen transfer, and I would try that rather than putting you into a surgery. Now, if there are symptoms as well, you might try to put a camera inside to see if there is severe endometriosis, stage 3, 4 endometriosis. Because, you know, if you have that much severe endometriosis, it can affect an unhealthy environment inside your tummy that can affect the implantation as well. So to do a bit of debulking of the disease and then go ahead with the transfer, since you have checked everything else, it might help. The question, I think I have answered the question, yeah? Yeah.
Yes. Thank you so much. And yeah, only there's a follow-up. Only slight symptoms at deep penetration. This is the
So
additional
it's not
information.
a matter of doing the laparoscopy for pain or anything like that, and the symptoms are not very severe. I don't know how you did the previous transfers. If we suspect endometriosis or we suspect it now and it was missed before, you can try down regulating as well with GnRH injections. Now, if you want to put a camera as well, okay, you can put it, but it's a surgery. So you need to balance a bit things. We have evidence that only severe disease of endometriosis, the bulking of it, might help the chances of success of an IVF. When it is minor disease, the downregulation usually is enough.
Yeah, again, thank you so much. I believe that was, again, useful information for you. And as I mentioned, looks like that was our final question. So thank you so much, everyone, for joining, for your questions, Dr. Harry, for your expertise and your time. It's always great having you here. I believe it was really, really helpful. I can see some thank yous, of course, here. You see them as well. Appreciate you sharing this information. Couldn't agree more, of course. So thank you, everyone. And Dr. Harry Karpouzis was our guest today, speaker from Athens. And before we finish, anything else you wish to add?
Nothing. I hope I've helped, and we'll discuss some interesting things again here. And thank you,
Definitely.
Caroline, for organizing and coordinating all that.
It's always lovely to have you. I believe it was a very useful session. Remember, it's been recorded. It will be available on our website tomorrow morning and on our YouTube channel. I can only encourage you to take a look at it. And you will find plenty of previous webinars with Dr. Harry, but other webinars as well. And I just want I also want to invite you for our upcoming event that will take place on Thursday, this Thursday, 7 p.m. Join us. We will talk about mitochondrial donation. So it's a bit different topic. Also interesting. If you have questions, join us on Thursday. Dr. Harry, thank you so much. Have a lovely evening, everyone. And of course, we will be back here quite soon as well. Take care.
Thank you.
Bye.
Bye bye, everybody.